Yeah, yeah.
Quickshot, so.
Yeah, I actually do. Yes, yes, this is it, right?
Yeah, just make sure you fill right. Do we know when he'll be here?
Which number was that? 37. So you want to just push that, push it to the end or something?
Okay. He does know he has to get her. Okay, so he has other things. So that won't.
Is it that one? That's the one that didn't show up.
Yeah, but he said he's coming and we'll do it at the end. So
So like that's over here. So
yeah, just the red one. Yeah. Here, let me. All right. Good afternoon. We're gonna. I know this is right before the dinner and stuff, so we're gonna do Quickshot Session 5, and I'm Dr. Bob Sticka from North Dakota, and next to me is Dr. Khalid Zarik. He's also from North Dakota. We actually practice in the same health system. So welcome everybody. And our first presentation, we just found out that the presenter is going to be delayed, and we're going to try and push it to the end of the agenda. So we're going to start with Quickshot number 38, which would be pregnant trauma patients with positive urine toxicology, a Southern California multi-center study. And I believe is it Dr. Clark is going to present this. And we're going to try to stick to the 5-minute presentations and then a couple minutes for questions. So.
Yes, sir. Good afternoon. Thank you to the Southwestern Surgical Congress for the privilege of the podium. My name is Isabel Clark, and I'm a current surgical critical care fellow at UC Irvine. And we have no relevant financial disclosures. Trauma is a leading cause of maternal and fetal morbidity and mortality. Pregnancy changes a woman's anatomy and physiology, which can make the care of pregnant trauma patients more challenging. Substance use may exacerbate existing risks and contribute to worse clinical outcomes. The link between substance use and trauma has been well established in the literature. We also know that substance use in pregnancy is increasing. However, there are relatively few studies concerning the rate of illicit substance use among pregnant trauma patients and their outcomes. Therefore, this study sought to evaluate clinical outcomes of pregnant trauma patients with positive urine toxicology. We hypothesized that pregnant trauma patients with positive urine toxicology would have worse outcomes compared to pregnant trauma patients testing negative for illicit substance use. We designed a retrospective post-hoc analysis of a multi-center study, including 12 level 1 and level 2 trauma centers in Southern California. We included data from 2016 to 2021. Pregnant trauma patients greater than 18 years of age were eligible for inclusion. We excluded prisoners, patients with missing data regarding urine toxicology, and patients testing positive for opiates, since most of these patients likely received opioids pre-hospital or in hospital for analgesia. We divided these patients into 2 groups, obviously those patients with positive urine toxicology and those with negative testing. We collected demographic variables, including age, gestational age, and substances found in urine. We also collected data regarding mechanism of injury, injury pattern, and clinical outcomes. We collected data on 852 patients. 84 or 9.8% were found to have positive urine toxicology. The age of patients were similar between the 2 groups, which is the top bar there. Patients with positive urine toxicology were further along in their pregnancies at 37 versus 30 weeks. THC was the most common substance use found with a rate of 57%, and amphetamines were the second most common with a rate of 44%. There's our little, in case you don't know what those look like. There are several things of interest on this slide. The first, pregnant trauma patients with positive urine toxicology are more common to be injured as a pedestrian struck by a car, and also in an assault. Also, pregnant trauma patients with positive urine toxicology sustain domestic violence at a rate of 21.4%, which is almost 4 times those with negative urine toxicology. In terms of injury profile, as you can see, patients with positive urine toxicology more commonly sustained head and extremity injuries, whereas all other injuries sustained at a similar rate compared to pregnant patients with negative urine toxicology screening. So for discussion, THC was the most prevalent substance detected in our study, which aligns with previous research highlighting the increasing use of cannabis during pregnancy. Studies have reported that prenatal exposure to THC is associated with low birth weight, preterm delivery, neurodevelopmental abnormalities. Methamphetamine use was the second most common substance found in our study population, with being linked to complications such as placental abruption, fetal distress, cognitive and behavioral deficits, just to name a few. Probably the most concerning thing to me was that we found a higher incidence of domestic violence and assault in pregnant trauma patients with positive urine toxicology screening. This finding is consistent with existing literature, which has demonstrated that substance use is a risk factor for experiencing domestic violence. And while pregnancy-associated deaths are declining, the rates of maternal mortality are higher in the US than other developed countries. And this is hypothesized to be because American mothers are increasingly dying of accidental causes, including homicide, suicide, and substance overdose. So our study highlights the need for further research on clinical outcomes of pregnant trauma patients with positive urine toxicology screening, particularly in relation to THC and methamphetamine use. The higher rates of domestic violence and specific injury patterns identified in this population underscore the importance of comprehensive care and targeted interventions for these vulnerable patients. Future studies should aim to clarify the underlying mechanisms and causal relationships, as well as explore potential strategies to improve outcomes for both mother and fetus in this high-risk population. I'd be happy to take any questions.
So did you guys recommend any kind of special monitoring for the positive toxicology patients with the, especially for methamphetamines and stuff?
Sure. We didn't, relative to this study specifically. In researching this, there was a wide variation of anywhere from 6 to 24 hours. There's really no standard of care across the centers.
Okay, any questions from the audience?
Yes, ma'am.
I have a question on your slide. You had the urine tox being positive was amphetamines. At least at our place, a lot of times when they're just positive for amphetamines, it could be pseudoephedrine or something in cold remedies. Did you guys look at that? Because that will give you a positive urine tox.
Sure. No, that's a great point, and we did not kind of tease that out further. I think it's also worth noting that opiates are very commonly abused in this population as opposed to given in the hospital. So I think that is something that I would like to delineate further with future research, is which patients are given opiates by the hospital system as opposed to taking them on their own.
Okay, any other questions or comments? If not, thank you very much.
Thank you.
All right, the next presentation is hospitals cashing in on COVID fake news for trauma patients, from Brittany Stansbury, St. Joseph's Hospital and Medical Center.
Good afternoon, I'm Brittany Stansbury. I'm a PGY2 at Creighton Phoenix. I have no disclosures. The CARES Act delegated over $100 billion in relief funds for healthcare providers treating COVID-19 during the pandemic period. A 20% add-on payment was given to hospitalized COVID-positive patients that had governmental insurance. And there was a general concern amongst the media and public that some of these payments were not necessary when patients were hospitalized for reasons other than directly related to their COVID diagnoses. The aim of our study was to determine if the COVID-19 reimbursement rate was justified for COVID-positive trauma patients. We conducted a retrospective review of patients admitted to our level 1 trauma center between April 2020 and December 2021, and stratification was completed according to the test result of COVID at admission. Inclusion criteria was for government funded insurance patients only. And then we utilized multivariate modeling to evaluate the impact of the positive COVID test on hospital reimbursement. As you can see here, we had 2,151 patients who met study inclusion criteria. 4.2% of those were COVID positive. There were no significant differences with respect to their demographics, their injury severity, or their comorbidities. COVID positive patients had a longer hospitalization, 8.2 days in comparison to 4.4 days. And these patients were also significantly more likely to be admitted to the ICU and be mechanically ventilated. COVID positive patients had a significantly higher median hospital costs, but those was actually offset by a proportionately higher reimbursement due to the 20%. And multivariate modeling demonstrated that COVID positivity was associated with an increased reimbursement rate of 21%. Here demonstrates the difference between COVID positive and COVID negative patients. The ICU length of admission for a COVID positive, 64%. And mechanically ventilated 54% in comparison to, 34% in comparison to 15%. And then the reimbursement, as you can see at the bottom bar graph, for COVID positive patients was almost completely reimbursed, 99% in comparison to COVID negative patients, which 75% of their hospital costs were reimbursed. This is a summary of our regression model. As you can see here, no significant differences in terms of their comorbidities. Down at the bottom, the COVID diagnosis, that's actually a logarithm. So it's 21% is essentially when you log that out. So in conclusion, the concern that hospitals were being inappropriately reimbursed for incidentally COVID positive patients was not warranted in our experience. We see here that actually the reimbursement rates were nearly identical for their total cost versus what was given by insurance. And COVID positive trauma patients utilize greater hospital resources compared to COVID negative trauma patients, as seen again by their ICU length of stay, as well as their mechanically ventilated days, and their overall length of stay was higher as well. The higher government reimbursement for this subgroup of trauma patients was in fact proportional to the cost of their care. I'll take any questions.
Dr. Stansbury. Sorry, Dr. Stansbury, your study was done during the early phases of COVID, right? I mean,
June 2021 to December, or June 2020 to December 2021, correct?
so that was when the COVID was a much more aggressive virus.
Correct.
So currently with the Omicron and so forth, the virus is not anywhere near as aggressive. And I wonder if you have any differences in admissions and severity.
Yeah, I think it would be very interested to stratify based on the new Omicron variant versus Delta and previous variants. I suspect that you're right, that there would be perhaps less of a difference in reimbursement need.
We have a question here.
Yeah, John Akar from Omaha, Nebraska. Very nice presentation. I was quite glad to hear your conclusion, because I was worried for a few minutes as you were presenting that you were going to challenge the validity of that extra government reimbursement. I had the sort of twisted honor of becoming chief medical officer at Creighton University Medical Center right as COVID began. And, it's been well reported in the news that hospitals have lost a tremendous amount of money, and the CHI system for which I work nationally lost almost $2 billion as a result of the COVID effect, mostly because of canceling elective surgeries. So I was simply, going to remind us all how healthcare economic works. There is a lot of cost shifting and a lot of secondary considerations that go into the cost of managing and running hospitals. There have been additional government payments besides just the standard CMS reimbursement, special one-time reimbursements for hospitals and for practices. And they have offset a little bit of the pain, but they in no way really made up for the total losses across the country in major healthcare systems. So I don't really have a question tied to this, but want to make that comment. Thank you for the presentation.
Yeah, absolutely. I agree with, basically everything you said. And I think it's highlighted in the fact that only 75% of costs were reimbursed for COVID negative patients.
So have these payments expired now, or is the CARES Act still, they still paying?
No, I believe it expired in January of 2022.
Okay. Any other questions or comments? If not, thank you. Very nice presentation.
All right. All right.
Okay. Next is a presentation about pre-hospital endotracheal intubation for severe trauma, a descriptive study. This will be presented by Dr. T.J. Chade by University of Colorado.
Well, thank you for the privilege of the podium and the opportunity to share our work. We have no relationships to disclose. Pre-hospital endotracheal intubation in trauma is a pretty debated topic with not a lot of data to guide its need and timing. Some literature supports that it has benefit, particularly in the TBI population, while others report it increases scene time and leads to worse clinical outcomes. Our group actually presented some data at the most recent Academic Surgical Congress in Houston demonstrating that attempted pre-hospital endotracheal intubation is inconsistently successful, delays definitive care, and appears to have no survival benefit. Despite all this, it remains ubiquitous in EMS practice. So we wanted to characterize those patients who underwent attempted pre-hospital endotracheal intubation and begin to investigate, well, what distinguishes those with failed versus successful attempts. To do this, we performed a cohort study at our Urban Level 1 Trauma Center. Adult trauma patients transported by ground ambulance with attempted pre-hospital endotracheal intubation were included. Interfacility transfers and air transported patients were excluded. Importantly, none of the included patients underwent rapid sequence intubation in the field, as this is not part of the EMS practice in our metropolitan area. And our statistical methods were as shown. So there were 102 patients with attempted pre-hospital intubation, 45 or 44% failed, and 57 or 56% successful. Age, sex, mechanism of injury, injury severity score, proportion with TBI and GCS were all similar between groups. While EMS scene time was not significantly different, patients with failed pre-hospital intubation were injured closer to the hospital. And the majority of patients with successful pre-hospital intubation had just one attempt performed. Patients with failed pre-hospital intubation were more likely to have injury to the anterior neck and require airway suctioning by EMS. And a fifth of those patients with failed attempts had reported difficult airway in the ED. Patients with failed pre-hospital intubation were also more likely to present pulseless, breathless, and more hypotensive on arrival. But importantly, regardless of whether EMS got the tube or not, mortality was high, 3/4 of patients among all pre-hospital intubation attempts. So in conclusion, attempted pre-hospital endotracheal intubation is unsuccessful in a large proportion of patients, and anterior neck trauma may play a role. These patients with failed attempted pre-hospital intubation present to the ED with more physiologic derangement. But regardless of success, any attempted pre-hospital intubation is associated with significant mortality. And given that the majority of successful pre-hospital intubations were achieved with just one attempt, these data may support a method where EMS gives it one shot, otherwise just get to the ED as fast as possible. And lastly, social determinants may underlie the differences we observed in proximity to the ED, and we plan to look into geographic location in future studies. Altogether, our data identify multiple crucial areas for future investigation to better guide the need, timing, and technique for pre-hospital airway management. I want to thank our amazing trauma research team and the contributors to this work at CU, and thank you again to the program committee and the moderators for the opportunity to speak today. I'll now take any questions.
Okay, thank you for the presentation. Looking at your numbers, you have 45% pre-hospital intubation failure. This data is in line with the current push nationwide to use alternative methods of airway management by EMS, as there is evidence now that pre-hospital intubation may do more harm than good. And this is due to a variety of factors, including the experience of the EMS personnel, etc. Your mortality data is also showing similarity in patients with a failed and successful PHI attempts, which also supports a theory that other methods of airway management other than intubation might have similar outcomes. So that said, I have a couple of questions. Do you know what were the other methods of airway management that were used during the failed PHI attempts? That's one of them. And the second one, is there a push at your institution to limit or reduce pre-hospital intubations?
Yeah. So to answer your first question, these were only, we did not look at any supraglottic airways in this or any other nasopharyngeal airways, anything like that. Well, nasopharyngeal areas, but no other pseudo definitive airway like a supraglottic airway. Those were not included in these patients. And then your second question was that, is there a push to
limit
that? Well, I mean, I think that's what this study is trying to get at. We're trying to get some high quality evidence to say, hey, there's, either give it one shot or just not even worry about it, especially in a large urban metropolitan area where your pre-hospital times are pretty low as it is. But this data was really exciting for us and has pushed us to continue studying this particular topic in our large multi-centered AAST trial. So that's to come, and there'll be a lot more data that we can get on a prospective basis that will help us in kind of getting down to these answers.
Okay, thank you. Dr. Seiler?
One last question. Jocelyn Seiler from University of North Dakota. Did you look at the type of intubation attempts? Were they video or were they direct?
We do not have that data. Yeah, that would be fascinating to look at. But yeah, it's we could probably go back into a lot of this. All those 102 patients were manual chart review to get this data, and so I'm sure we could look at those EMS trip sheets and see maybe delineate a little bit better if method of intubation had any effect.
Any other questions? Okay, thank you very much. Okay, next is pre-hospital use of whole blood in pediatric trauma patients. Initial experiences by Dr. Kelly Harrell at University of Texas Health Sciences at San Antonio.
Hello. Hello, and thank you for the opportunity to present today. I have no disclosures. I'd like to start this presentation off by answering our why. Why do we choose to transfuse people in the pre-hospital setting? Can anyone tell me where they were on May 24th, 2022, around 10 a.m. Central Time? My guess to that answer is probably no, unless you live in Texas and/or knew someone personally involved in the Robb Elementary School shooting. I was post-call and was abruptly woken up to numerous text messages regarding a mass casualty incident and needing backup, seeing as we're the only pediatric level 1 trauma center covering 26,000 square miles. However, when I called to see if they needed me to come in, they said that most of the patients we were hoping to treat didn't make it. There was one though, one that made it through our door where she received low titer O positive whole blood and whose life was saved in part by the blood administered on the way. And as well as the extensive efforts of the teams providing care. Despite enduring multiple gunshot wounds to the chest, arm, and back, she survived to throw the first pitch at the Astros game just a few months later. So now for some background. The leading cause of death in trauma in people less than 44 is trauma. And unfortunately, firearm injury overtook motor vehicle collisions as a leading cause of death in pediatric population. We also know that hemorrhage is the leading cause of preventable death in trauma. So if trauma is a massive problem and hemorrhage is the leading cause of preventable death, why not give trauma patients what they bleed? So from this point on, I'll be using low titer O positive whole blood and whole blood interchangeably. And why do we use whole blood? Literature has shown and our program believes that it is a physiologic solution, it has a longer lifespan, there are less anticoagulants and preservatives, lower transfusion volume, it's easier for nursing to administer, and there's less exposure to multiple donors. So given the aforementioned benefits to whole blood, we created a multi-institutional consortium comprised of UT Health San Antonio, our Level 1 Trauma Center, EMS, the local blood bank, and the Southwestern Regional Advisory Council that we call STRAC. You might be asking yourself, what is STRAC? STRAC monitors time urgent medical events and deploys resources as necessary. It covers a large encatchment in Southwest Texas, covering about 26,000 square miles. And as you can see on the map, it's centered around 2 Level 1 trauma centers in San Antonio, University Hospital and Brooke Army Medical. We use the same criteria for transfusing whole blood as we do for component therapy in both the pre-hospital and hospital settings. So what were our objectives? The primary objective was to describe our initial experiences at the experiences of pre-hospital whole blood in a pediatric population, as it's well studied in adults but has not been studied in kids. And secondarily, to evaluate the safety and efficacy of using whole blood in pediatric trauma patients in the pre-hospital setting. We conducted a retrospective chart review and utilized a whole blood specific database that our trauma research office created. The database logs each patient that receives whole blood and tracks their outcomes, course of care, and any adverse events. From the timeline, you can see that we started transfusing males greater than 10 in 2018, and then expanded that to male and female greater than 2 in July of 2021. In our system, we were able to identify 22 patients that received whole blood prior to arrival. These patients ranged in ages from 3 to 17 with an average age of 12. About half were males and 64% suffered penetrating injury. 8 of them were actively receiving CPR en route to the hospital. And as you can see by the injury severity score and the GCS, they were all very sick. What we saw after whole blood transfusion were that there were 0 reported events of severe transfusion reaction and no incidents of venous thromboembolisms. However, there were other noted events such as 4.5% experienced acute kidney injury, whereas 9% experienced ARDS, and 1 rash was reported in a patient. The overall 27% of the patients in our study were pronounced dead on arrival, and our overall mortality rate was 45%. So in conclusion, to our knowledge, we're the first institution to start integrating the use of whole blood in the pediatric patient population in the pre-hospital setting. Our early data show that whole blood is used in the most severely injured patients. The high mortality rate may reflect the patient population and nature of their injuries rather than the efficacy of whole blood. And there was no reported significant transfusion or VTE reactions. And therefore, further studies are needed to evaluate the safety and efficacy of pre-hospital use of whole blood in pediatric patients. Thank you so much, and I'll take any questions.
Thanks for the nice presentation. There is ample evidence in the literature that whole blood in general is safe to administer.
Yes, sir.
Long-term outcomes are still unclear. So nice work addressing this issue, particularly with the focus on the low titer O positive blood in the pediatric population, which is the focus of the study.
Yes, sir.
Now, looking at your data, it seems that 10 of your 22 patients had non-survivable injuries. So 10 out of 22 died either early upon
Yes,
presentation or in the OR.
Yes, sir.
So you were left only with 12 patients that were given whole blood, and they survived the next 30 days.
Yes, sir.
So you had good outcomes with these 12 patients.
Yes. Well, yeah. Yes, sir.
So my question here is the correlation more observational that whole blood administration in that subset of population is just associated with severity of injury? Because otherwise you had good outcomes in these patients.
Can you say that? Wait.
So my question is I'm just looking at about the hypothesis. The hypothesis of this study is we're giving blood to patients who are injured,
Yes,
severely
sir.
injured. That's the hypothesis?
Yes.
Okay. And do you think the 12 patients are going to be enough for this study?
No, it's definitely underpowered.
Okay. Okay. All right. Any other questions?
Yeah, John Akar again, a very nice presentation. I guess I was going to ask similar along the same lines because the mortality rate was so high and easily
sir.
attributable to the severity of injuries.
Yes, sir.
I'm not sure that those patients would really be analyzable in a study. And so if you recalculated your rates of what were possibly minor transfusion reactions, right? No major reactions.
Yes, sir.
Your numbers would look a little bit different because among survivors is the ones that you'd really have to assess whether or not there were
The 12.
reactions.
Yes, sir.
It dilutes it a little bit if you count all the patients that died from injuries.
Right.
But the question I was going to ask relate to blood banking
Yes, sir.
issues. The whole blood initiative kind of, well, it's come off and on historically if you look back through time, but it's been brought back up through the military experience.
Yes, sir.
And blood banking in the military is a little bit different than blood banking in the civilian world, in that they use soldiers for donors, have availability, and
Yep.
a lot of logistical things that they have under their control that much harder to control. But I was going to ask about, do you have any idea of what the age of the units, that is, how long after donation you have? Because if you don't get blood back into use and into circulation
Yes.
within a period of time, it expires. So
Yes, sir.
there's not only cost concerns, but there's a storage lesion associated with keeping blood
Absolutely.
in the bank. So is there any feel for the availability of whole blood, whether you cycle through it enough to justify keeping that as a source,
Absolutely.
and whether storage lesion may or may not be an issue?
Yes, thank you so much for your questions. So in terms of the lifespan, we use a 35-day lifespan. San Antonio has built a very robust this whole blood consortium. And so the way it's kind of distributed is the units will go out onto EMS. If they're not used by the peripheral hospitals or by the EMS after 14 days, they get cycled back into our main level 1 trauma centers so that they're getting used in a timely manner. I don't recall we've done a study on this, and I don't recall the exact percentage of waste, but it's incredibly low. And in terms of, it's 0. My bosses are, yeah, it's like, yeah. And then in terms of cost, we actually just did a cost analysis comparing component therapy to whole blood and what it's kind of saved our institution over time. And there was a significant cost savings after implementing our whole blood program. Now, that being said, there's a lot of back work that went into going. Our blood bank developed a set program where we have donors that just donate low titer O positive whole blood. It's called Heroes in Arms. It's a wonderful program, and I highly encourage anyone who's interested in that to look into it, because they, yeah, it's phenomenal, and it doesn't detract from normal blood donation.
Excellent, thank you.
Yes, sir.
Okay, thank you very much.
Okay, our next talk is on rugby in the COVID-19 era, a comparison of incidents in rugby-related emergency department visits by Dr. Arif from the University of California, Riverside.
Good afternoon. My name is Had Arif. I'm a second-year medical student at the UC Riverside School of Medicine. I would like to begin by thanking the Southwestern Surgical Congress for inviting me to present our research today. Me and my co-authors have no relevant disclosures. So, rugby is a full contact sport similar to American football and lacrosse, played with little more protection than cleats and a mouth guard. Nonetheless, it is the 9th most popular sport in the world, with American interest steadily rising throughout the past decade. It is played by men and women alike and athletes of all ages, beginning as young as 6 years old. Return to practice following extended absences has raised concerns for increased risk of injury due to athlete deconditioning and loss of physical fitness. Prior studies have shown that ED visits due to contact sports has shown a decrease in COVID-19. Prior studies have shown that ED visits due to contact sports have decreased during COVID-19, while absolute injury incidence has increased. We sought to investigate whether rugby displayed a similar pattern of decreased ED visits. Using the National Electronic Injury Surveillance System, we looked at all relevant rugby-related ED visits over the past year and a half. We divided our resulting cases into two 21-month-long periods, so beginning from June 2018 to March 11th, defined as pre-COVID-19, and post-COVID-19, defined as March 12th, 2020 to December 2021. Overall, we had a total of 654 ED visits with a roughly 0.5% decrease during COVID-19. Notably, we saw a significant decrease in the months of January, March, and July, with a significant increase in the month of May and October. Overall, we had athletes of male gender, Caucasian, and age 16 to 20 years old across both study periods. However, we did notice multiple significant changes during the post-COVID-19 pandemic. We saw a significant increase in males, injuries to the trunk, lacerations, and hemorrhages, as well as a significant decrease in females, sprains and strains, as well as schoolyard injuries. These changes in the ED presentation patterns could be attributed to three major factors: rugby participation, injury severity, and societal regulations such as lockdowns and league closures. In the face of COVID-19, athletes may be more hesitant to seek medical care due to various reasons, but COVID-19. And this biases our results to more quote unquote severe injuries such as fractures and dislocations. Prior studies have shown that males are more susceptible to said injuries, whereas females are more likely to sustain superficial injuries such as contusions and abrasions. This has been proposed to be due to the mechanism of injury, where males are more likely to be injured during contact with another player, whereas women are more likely to be injured during collision with the ground. Overall, we had a decrease in rugby-related ED visits during the post-COVID-19 pandemic era, which could be attributed to a sizable proportion of school-age athletes to the pre-pandemic level ED visit levels, as well as an increase of emphasis in injury prevention by organizations such as World Rugby and USA Rugby. In general, clinicians must be aware of potentially untreated rugby-related injuries that may have long-term implications and chronic injuries. Thank you for your attention. I'll open it up to questions.
Thank you. That's a good presentation. I guess I'll admit we don't play a lot of rugby in North Dakota, but I can tell you, a few years ago I gave a talk at the Australasian Surgical Society, and they gave me a rugby ball. And I wasn't quite sure what to do with it. I still have it at home, but maybe I'll have a better idea now. So the question I would have for you is, so it sounds like you got two variables. You had the COVID pandemic, and then you have this initiatives by the World Rugby Society to decrease the injuries. And they both were sort of going on at the same time. How were you able to separate those things at all, or?
So not with this data set, we're not, but also all of those injury prevention mechanisms were mostly theoretical until 2021 when gameplay started again. And so the majority of our data isn't towards that year, if that makes sense.
Yeah.
But no, we were not able to delineate between COVID-19 and the injury prevention mechanisms.
And you're hypothesizing that there may have been more injuries, but some people are just staying home because they didn't want to go to the hospital with the COVID virus?
Correct. One of the limitations is that we don't have an absolute injury incidence, and this is simply who's presenting to the ED. And patients who present with maybe concussion, who don't present with concussions, which are seemingly benign to the general public, we might be underreporting that in our study.
Okay, good. Any other questions? Any other rugby players here? No?
No, just me?
Another question, but just a small note. You put like pre-COVID and post-COVID. We now refer to post-COVID like end of COVID. I think you were referring to pre-COVID and during COVID.
During COVID.
The comparison
Right,
between the
definitely.
two. All right.
Thank you.
Thanks. Yeah.
Okay, thank you very much. All right, our next presentation is pediatric skull fractures in the emergency department from 2012 to 21. Dr. Tariq from the University of California at Riverside.
Sorry, I didn't know I was next. Hi, my name is Aisha Tariq, and I'm a third-year medical student at UC Riverside School of Medicine. Your doctor soon. Because you referred to me as doctor. I'm a medical student.
Oh, I'm sorry. Well, you will soon be then.
Yes. Okay, so let's get started. I'm going to talk about pediatric skull fractures in the emergency department from 2012 to 2021. We have no disclosures. Head trauma is a leading cause of disability and mortality in children. There are over 600,000 ER visits per year for blunt head trauma. Children are more susceptible to brain injury because their skull is thinner and more pliable, thus protecting their brain less. There are two categories of skull fracture causes, accidental and non-accidental injury, with the most common being accidental falls, especially in kids 2 and under. Sports injuries and motor vehicle accidents are also a common cause of skull fracture injuries. So current literature states that one of the leading mechanisms of injuries in peds TBI patients are falls, which are mostly seen in males. Another study showed that the most common fracture in peds patients under 12 months old presenting to the ED were skull fractures. Our study focuses specifically on pediatric skull fracture similarities and differences in males and females, ages 0 to 17 years old. We use a retrospective descriptive study. We looked at, again, pediatric skull fractures over 10 years from 2012 to 2021. The data was extracted from National Electronic Injury Surveillance System. The NEISS pretty much collects data from about 100 hospitals with 24-hour emergency departments, at least containing 6 beds. We did univariate analysis. That's what we performed and examined differences between male and female skull fractures using multiple variables. This is what we found. So by year, we saw an increasing trend with significance in the year 2020, with females sustaining more skull fractures at that time. We also looked at month. The most significant months were January and February, and May and June. And as you can see, in May and June, males statistically had higher skull fracture injuries. We also looked at age group, 2 and under, 3 to 5, 6 to 10, 11 to 14, and 15 to 17. The most common injuries were found in children under 2 years old, with females having the most. 11 to 14 and 15 to 17-year-olds, mostly males sustained skull fracture injuries. Location was most commonly seen at home, injuries caused at home, with females having more skull fracture injuries at home. Sports and street were more commonly seen in males. This looks at products. All of these products are statistically significant, with floors and flooring materials being the most common skull fracture injury. Females sustained a lot more skull fracture injuries compared to males. They're 1.5 times more likely to get an injury. So discussion. Again, we looked at the trends, with the highest being in 2020. Skull fractures occur mostly in children 2 and under. There were key differences seen in males and females by age group. Referring to the study I mentioned earlier, it kind of agrees with the 12 months and under having skull fractures. And skull fractures are mostly seen with product. There are some other studies that also agreed with part of what we were saying, but they left it more general, talking about house surfaces. And we talked more about floors and flooring materials, stairs, steps, counters, countertops, sofas. There are limitations, including the NEISS database and the collected variables. So in conclusion, we looked at pediatric skull fractures presented to the emergency department from 2012 to 2021, recorded by the NEISS, and we saw statistical significance in males and females by year, month, age group, location, and product. Again, multiple variables were unaccounted for, the stuff I mentioned in limitations. Further research should be done, maybe in multimodal preventative measures, targeting patients, why injuries happen, the causation, and mechanism of injury, and looking at treatment and outcomes in the ED. So my references, and thank you.
Thank you. Very nice presentation. I couldn't tell from reading the abstract, but maybe in one of your graphs it was better represented. Did you see an overall increase in the number of fractures over the 10-year period? Or was it stable or?
It was an overall increase. 2021 had a little bit of a decrease compared to 2020, but it was an overall increase with
Okay.
males sustaining consistently more.
And is that, do you think that's just specific to your study, or is that a national trend?
It's a good question, because our study only looked at one database, so maybe, I don't know. That's a good question. We'll
Okay.
look into that. Thank you.
All right, we have a question from the floor.
Thank you. Thank you for the presentation. Very interesting data. Were you able to tease out patients who like trends in non-accidental trauma? Because like we know like less than 2 years old was the most common like group increases. So were you able to see the trends in non-accidental trauma among these children? And do you think the COVID-19 pandemic and the lockdowns has anything to do with this? Thank you so much, and very interesting. Thanks.
I think I only heard part of the question related to COVID-19 and the trends in age groups. Is that what you were saying?
Trends in non-accidental trauma, child abuse.
Oh, non-accidental.
Was that related to that? Did you find any trends related?
We mostly looked at accidental injuries. The data includes non-accidental, but I wouldn't know the answer to that. I mean, COVID definitely had the highest, so that's something maybe we should look into.
Thank you so much.
Thank you.
I think what he was alluding to, your highest month of accidental trauma was April, May, and June 2020. This is the beginning of the pandemic. Is
That's
that
right.
correct? Why do you think this happened though? Kids are at home, so they're worse off at home than at school?
That's a good question. I mean,
Looks like it.
parents
They
might
fall
be
less and they
annoyed. I
break the
don't know.
skulls.
That was a terrible answer. Maybe they are finding more play indoors and they're hurting themselves more. I don't.
Okay.
But the most common way to get injured was a fall, right? Hitting the
Yes.
floor, right? And especially for
Floors and falling,
the
yes.
younger kids, right?
Yeah, 2 and under. Yes.
Okay, I think we have one more question.
Just a quick comment. My wife happens to be a pediatric nurse practitioner, and she never misses an opportunity to remind me that something like 85% of childhood injuries occur when the father is watching the child. And I hate to be
That makes
sexist or
sense now.
anything, but I can kind of imagine that being accurate.
That makes sense.
And you said that into a room full of almost men. Thank you.
Any other questions?
Are you going into neurosurgery?
No.
Well, you'll be prepared if you do. So, all right. Thank you very much.
All right. Dr. TJ Scheid will be presenting again. Severe liver injury mortality remains high, inequitable, and unabated across the nation, an opportunity for improvement.
Great. Well, thank you. Yeah, different topic than my earlier talk. So thank you again for another opportunity to share our work. We have no disclosures. The liver remains one of the most commonly injured abdominal organs, and high-grade liver injuries, defined as AAST grades 4 and up, continue to be a lethal condition. There are a number of different management strategies to deal with these injuries, including non-operative management, surgery alone, angioembolization alone, or a combination of the two. Despite being a major contributor to trauma morbidity and mortality, high-quality evidence to guide best management of major liver trauma is lacking. There have been several smaller series published years ago, which include one of the largest and oldest by Cogbill and Moore, as well as a little later in the early 2000s, Asensio and colleagues' 8-year experience. More recently, the group out of Harvard UCLA described 103 high-grade liver injuries at their single center. These studies have certainly been valuable, but a more recent broader analysis examining changes over time is lacking. So we aim to use a nationally representative data set to analyze trends over recent years in the management and prognosis of severe liver injury. We hypothesize that survival of severe liver injury has improved due to advances in hemorrhage control. We use a TQIP database from 2013 to 2018, including adults with AIS of the liver 4 or 5, which is the same as AAST grades 4 and 5. And we excluded outside transfers as well as ISS 75 and AIS 6, as these are uniformly fatal. The injury was considered isolated if no other body region AIS was greater than 2. Management strategy was defined by ICD-9 and 10 procedure codes and included laparotomy, embolization, laparotomy plus embolization, or non-operative, which were patients who had a CT scan and survived beyond an hour. Early deaths were patients who did not survive to an hour and had no procedures performed. And to adjust for confounders, we used Cox proportional hazards models with robust standard errors to account for facility clustering. So there were 11,624 high-grade liver injuries from 2013 to 2018. Majority were male and bluntly injured, with over a fifth isolated injury and 18% with concomitant TBI. 71% were grade 4 and 29% grade 5. And overall mortality was 23%. Patients were mostly young and pretty badly injured in general, with many spending time in the ICU and on the ventilator as expected. As we start to look at trends and major risk factors for mortality, we see that rates of TBI remain stable, while injury severity score actually decreased significantly over time. Blood pressure on arrival actually increased significantly over time, so we can at least say that patients are not arriving more hypotensive. But overall, the data on these major risk factors for mortality, TBI, ISS, and hemorrhagic shock, all point towards stable, if not improved, risk for mortality. Taking into account early deaths and adjusting for confounders, the use of non-operative management and embolization increased while the use of laparotomy decreased significantly over time. Interestingly, there was wide variation in management strategy across institutions. Shown here is for the latest year, 2018, showing number of patients for each management strategy by institution. There is evidence that we're getting patients to the OR or angio suite sooner. Time to intervention is on the y-axis here with year on the x. You can see that median time to hemorrhage control was significantly lower in 2017 compared to 2013, and in 2017 and 18 compared to 2015. Now, don't squint to try and see things here. This was our Cox proportional hazards model for mortality, but bottom line, after robust adjustment for multiple variables, there was no change in mortality over time. A few other interesting things to point out, though. Embolization alone and in conjunction with operative management was significantly associated with improved survival. Additionally, something that isn't a new observation in trauma, but a consistent finding in this subset of injured patients, uninsured status was an independent risk factor for mortality. Importantly, when we include only patients who had hypotension on arrival or exclude all patients with TBI, or even just look at grade 5 or even just isolated liver injury, we see nearly identical results as these findings. So in conclusion, after rigorous risk adjustment, mortality of severe liver injury remains high and unabated despite stable, if not improved, risk for mortality, including a potential improvement in time to hemorrhage control. There's been a shift towards embolization and non-operative management, but there's wide variation in management strategy. The use of embolization may offer a survival benefit, but we certainly need prospective studies to investigate this better. And lastly, uninsured status was an independent risk factor for mortality, which highlights the very real healthcare disparities that exist within trauma and stresses the need to continue studying social determinants of outcomes in our patients. I want to thank all the contributors to this work, and thank you once again to the program committee and the opportunity for me to be here. Thank you.
All right, very interesting study. A lot of data for just a quick shot.
Yeah.
All right, so I gotta tell you, as a trauma and critical care surgeon for the past, I've been in practice for the past 15 years. The worst cases I ever had were the trauma liver patients. When they come with this severe liver injury and IVC injury, and I had a lot of death with these patients. And these cases I keep on remembering. So going back to your study, looking back at the trends of liver injury mortality, and looking at your methods after you excluded the early death, you noted no decrease in mortality. And your initial data was a decrease in mortality from 31 to 21%. So you had initially 31 to 21%, and then if you excluded early mortality, you had no change.
Correct.
So for me, if I'm just doing it mathematically in my head, this can mean many things, but one of them is that you had a lot of early death earlier, and then your mortality attributed to early death is decreasing. Am I getting this right, or there's another?
Well, so I think that was the raw. Those were the raw.
Yeah,
when you looked at
numbers
it, that was the
show.
raw numbers. But then when we adjust, when we use our
Yeah.
rigorous risk adjustment, that's when we see that there is no significant difference. It's not that there. I mean, I think our the parameter estimate was actually negative. It was a small number, and our p-value, was close to. It was just under 0.5. So there's maybe a trend towards it, but when we consider all of these major risks for mortality and significant covariates, we do not see a difference. Yeah.
Because your adjustment also excluded the early death.
Yes. Yeah.
Okay. All right. So the other one is, can you elaborate more on the inequitable situation? Because most of the time, lack of insurance is associated with low socioeconomic status. And usually that's associated also with more severity of injury.
Yeah. Yeah.
So it's not like somebody comes to the ER and we're looking at them and, oh, it doesn't have insurance, I'm not going to take care of them.
Well, can you say that for sure?
So they come to the ER, I don't know their insurance situation. When they show up,
Yeah,
with
so,
a liver
yeah.
injury, I don't know their insurance. This is not an elective situation.
Right.
This is a traumatic injury.
Right. And I think it 100% speaks to other variables that are collinear with, or associated with uninsured status that we're not capturing. We can't capture in our TQIP databases or really in other databases that falls into this area of social determinants of outcome, because that data was an independent. Uninsured status was an independent risk factor. So taking into account injury severity, blood pressure on arrival, demographic factors. So it's at least not involving those other adjusted variables that has to do with their uninsured status. And so that's why, we need to continue studying this. We need to figure out, you could try and get down to the bottom of why was that an independent risk factor, and continues to be in trauma patients.
Okay. Any other questions?
Isabel Clark from UC Irvine. I don't know if you have any way of even parsing this out, but I'm just curious if there would be some way to figure out if there's a higher survivability in centers that are also either liver transplant centers or do a fair amount of liver surgery. Because at least in my own very small personal experience, if I'm working with an anesthesiologist that is used to having a patient that they'll tolerate more hypotension, I guess, if that makes sense, which I think in general leads to a better outcome. That's just a thought. Or
yeah, it's an excellent thought. And something else, again, the purpose of this study was not to look at embolization or even a specific intervention and its efficacy and compare it to other strategies. But one thing that I think we would look for in future, right now we're actually trying to merge 2019 and 2020 TQIP years to get a more broader, go 2013 to 2020, and then do a lot more analysis with. And I think one of the things we'll look at is volume centers, difference by the volume of these types of injuries, as well as now you bring up a great point about maybe looking at the types of other specialists that they have at those centers. So that's definitely a great point and something we'll consider.
Just a quick comment, really nice presentation. I presented a Quickshot probably 10 years ago here, blocking on the first author's name, and published on your social determinants of health question. Insurance status also is a negative predictor for survival after resuscitative thoracotomy. So you would think that should be equivalent, like It's but it predicts lack of survival from resuscitative thoracotomy too.
Yeah, I mean, excellent point. There's a lot more that we need to parse out and figure out why that is the case. And this is just another study another area of trauma where that finding is present.
All right, thank you very much.
Thank you.
Okay, we have another liver injury paper. Dr. I hope I'm not murdering this name, but Haseenpour from the University of Arizona, non-emergent hepatectomy among patients with severe traumatic liver injuries.
Good afternoon. I'd like to thank the ACS committee, the Southwestern Surgical Committee, for the opportunity to present our study. I have no disclosure. There has been a dramatic shift toward non-operative management of liver trauma. However, operative management remains the inevitable approach to hemodynamically unstable patients with high-grade injuries. Looking at the latest guidelines, damage control laparotomy is recommended for patients with major uncontrollable bleeding. However, when we look deep into these guidelines to identify the optimal time to hepatic resection among patients who might require resection, either we cannot find any recommendations or guidelines like World Society of Emergency Surgery prohibits hepatic resection at the first stage of damage control laparotomy. But there is a lack of data supporting this concept. So the aim of our study was to compare the outcomes of patients with high-grade liver injuries who underwent damage control laparotomy and hepatic resection within the initial operative stage of DCL versus those who received resection within the next take-back operation. And we hypothesized that time to hepatic resection might be associated with outcomes. To answer our question, we performed a 4-year retrospective analysis of ACS-TQIP. We included adult trauma patients with high-grade liver injuries, which was defined as AAST organ injury scale more than equal 3, and those who underwent damage control laparotomy and hepatic resection. We also excluded patients who were died within 24 hours and those who were transferred. Patients were stratified based on time to hepatic resection into emergent and non-emergent group. Emergent group were basically patients who received resection within the initial operative stage, and non-emergent group were those who received it in the next take-back stage. Our outcome measures were in hospital mortality, complications, and hospital and ICU length of stay. Out of more than 900 patients who met our inclusion criteria, we found 650 patients with emergent resection and 244 patients with non-emergent resection. Looking at the baseline characteristics, there was no statistically significant difference in terms of patients' demographic, ED vitals, and comorbidities. Regarding the injury characteristics, both groups had comparable injury severity score, abdominal AIS, and other concomitant body region-specific AIS. However, patients in the non-emergent group were more likely to suffer from higher-grade injuries. And ultimately, there was no significant difference in terms of other concomitant intra-abdominal solid organ injuries among our study groups. Looking at the interventions and time to procedure, a majority of patients underwent exploratory laparotomy within the first hour of admission with a median time of 46 minutes, with no significant difference among the study groups. And patients in the emergent group underwent resection with a median time of 44 minutes and non-emergent group with a median time of 33 hours. Patients in the non-emergent group were more likely to receive adjunct therapies like liver angioembolization, hepatography, and drainage placement. However, among those who received angioembolization, there was no statistically significant difference in terms of time to procedure. And finally, Both study groups had comparable 4-hour blood product requirement. This table demonstrates the main outcomes of our study. After controlling for confounding factors, although non-emergent hepatic resection was not associated with mortality, it was independently associated with higher odds of overall complications, including acute kidney injury, unplanned intubation, ICU admission, and return to OR, as well as longer hospital and ICU length of stay. In conclusion, delaying hepatic resection to the subsequent operation might not be associated with mortality. However, it was identified as an independent predictor of higher complications and hospital and ICU length of stay. And of course, future efforts should focus on validating these findings and incorporating them into the current guidelines. I'd like to thank my mentor, Dr. Joseph, and the Division of Trauma at University of Arizona for their constant support. Thank you.
Okay, thank you. That's a very good presentation, very interesting. So were the patients that were operated on had the delayed hepatectomies, was that because of continued bleeding or ischemia of a segment of the liver?
Unfortunately, we cannot differentiate that based on the TQIP database, and it's a kind of retrospective, and we just abstract the database on the ICD-10 diagnosis and procedure code. But we are assuming that these patients had uncontrollable bleeding because of their mean blood pressure, heart rate, the procedures that they received, and moreover, I mean, we didn't have enough time to present that data, but most of these patients received liver packing at the first stage of damage control laparotomy. So
I understand that you have some limitations in the data gathering and so forth, but it seems to me if you have somebody with a liver injury and they're in your ICU and you're transfusing and doing whatever you can to try to stop the bleeding, and then 24 or 48 hours later that you decide you're going to have to go back to the OR.
Mm-hmm.
That just by what's happened in those first 24, 48 hours, they're going to be a sicker individual and be at higher risk for some of the things that you showed in your study. Is that something that you guys considered?
Honestly, this is, I think I should make it clear that all these patients, I mean, the abdominal fascia were left open because these codes that we used is only for damage control laparotomy. So all these patients were supposed to go back to OR, and they went back to OR, at least for just checking out and abdominal closure. But the second group, which is the delayed group, and we named it as non-emergent group, received resection in the take-back operation, not at the first and initial stage.
Right, and so the real question would be, why did they receive a resection? Was it because when they went back in, they saw a dead segment of liver, or was there continued bleeding that required the resection, which I think
we cannot answer that question properly owing to the retrospective nature of the study. But I just want to mention that when we look at these two groups and the baseline characteristics, demographics, ED vitals, comorbidities, 4-hour blood product requirement, injury scores, when we look at the similarity of that, I think it's safe to assume that most of these variety is because of surgeon's decision, and it was at discretion of surgeon to decide that wants to pack and just go out or do it in the next take-back operation. But I agree that it's a major limitation that we cannot differentiate.
Sure. Okay, do we have any other questions from the audience? If not, thank you very much.
Thank
Very
you.
good. Okay, our next presentation is by Dr. Looks like a medical student, Nolan Langford, epidemiology of drinking straw-related injuries, presenting to the emergency department from 2012 to 2021. Got everything from rugby to drinking straws here today, so.
It's going to be quite a change of topic. So my name is Nolan Langford. I'm a first-year medical student at the University of California, Riverside, and today I'm going to be presenting on the epidemiology of drinking straw-related injuries. I don't have any disclosures. So a little bit of background. Plastic straws were introduced to the masses in about the 1960s to eliminate, the cleaning and the hassle of traditional glassware that they had in the home and in restaurants at the time. Since then, it's amassed to about 500 million plastic straws being used on a daily basis in the United States. However, with this adjunct of convenience, there has been a lot more concern for the impact that they may have on the environment, particularly marine wildlife, with the most notable example being a video in 2015 of a plastic straw being removed from a turtle's nostril that amounted to 35 million views on YouTube. So with this push for eco-sustainability, a huge market exploded in the reusable straw related market. With this, everything's great. You can enjoy your drink, no guilt of pollution or harming any wildlife. However, we are now also seeing that there are a lot more injuries of humans being hurt by reusable straws, particularly those made of metal, with the most recent case being last June when this 4-year-old boy, Charlie DeFria, punctured his carotid artery with a metal straw on his front porch after drinking a drink with a metal straw. So we're left at the stalemate. We see that the wildlife injuries come from the plastic straws, but reusable, sustainable straws can hurt us. So this is what we're going to be investigating in this study. So the National Electronic Injury Surveillance System was queried for product 443, which is any injury related to a drinking straw. Through this regular epidemiological data, such as age, sex, date, and mechanism of injury was extracted, as well as querying all of the narratives for different straw materials, such as metal, glass, rigid plastic, and disposable. So looking at straw material with regards to material, metal straws showed a 12.8% increase in all drinking straw related injuries over the study period from 2012 to 2021. We see the increase from 2017 to 2018 with the biggest jump from 2018 to 2019. Other sustainable materials did not show a similar trend. Over the study period, 1,174 cases were queried. We did see a 46.5% increase in injuries throughout the study period, with the mechanism of injuries being most common of poking injuries, running and falling with a straw in the mouth, and foreign bodies such as playing as like a chew toy. It should be noted that out of all of the drinking straw related injuries, 46.3% of all of these injuries were related from an injury due to a straw for using a straw other than a drinking conduit for any other reason such as a play toy. So looking at the general epidemiology between males and females, the mouth was the most common site of injury, I think for obvious reasons, with the eyeball and other internal structures being the second and third most common. As for diagnosis, contusions and lacerations and ingestion were the most common. As of the significance, there was no significance found between gender and age or injury location and diagnosis. The only thing that was found was that 4 to 6-year-olds are most common to have lacerations with straw injuries. It also should be noted that most of the injuries were sustained, about 60%, by people or children from the ages of 0 to 5 years old. So we see these metal straw injuries increasing. And why is this? This could be due to a couple things. There could be because of the regional ban of plastic straws in certain areas of the United States. This could be from increasing consumer market, wanting to be more sustainable, having more of a sustainable impact on the environment, or simply COVID-19 era boredom among children being unsupervised with a straw. But in conclusion, the additional data needed to really determine if metal straws are inflicting injury at a disproportional rate is still needed to draw any definite conclusions. So prevention measures. So this could include something of just not walking when you're using a drinking straw, not using it for anything other than a straw, or closely monitoring children when they are using one, or just forego using a straw altogether. I know myself, I'm not a big fan of paper straws, but if that's what you like, go ahead and do that. So physicians should remain aware of something like this because I think it's often an overlooked type of injury that is not usually anticipated. And I'll leave off with this. Everyone always grew up being told not to run with scissors. But now that metal straws are on the rise, this is something that should be considered and kept in mind for anybody presenting to the emergency department. Those are my references, and I'll take any questions.
Thank you. Very good. So aren't there like paper straws? I mean, were they are like cardboard or something? I mean, are they all, I saw plastic, glass, metal, and so forth.
Yeah, so that is one of the limitations with the NEISS database is they're very limited narratives on the type of material. So if it didn't explicitly say it, it was referred to as disposable plastic just because that's the most common thing you would think with like a juice box straw.
Yeah.
But I don't think there would be any paper straw injuries present to the emergency department. I don't know. Some people surprise me sometimes. You might get injured by a paper straw, but everything that wasn't explicitly said, metal, steel, glass, rigid plastic was assumed to be as a disposable plastic straw.
Okay. So the other question I have, and I couldn't quite figure out from the abstract was the total number of injuries increasing or was it just the metal straw related injuries?
Both. So the total number of injuries from 2012 to 2021 increased 46.3%, but metal straw injuries from over the study period also increased 12.8%. So going from like 0 in 2012 to up 12.8% by the time it was about 2021.
Okay, good. Any other questions or comments from the audience?
Just want to be sure of keeping this in perspective. You're talking about 300 cases a year?
It was a lot less in 2012, 2013. Definitely increased a lot more towards the later years, like 2016.
And this is in the United States?
Yes.
Because we have a population of 300 million, 350 million. Is that correct?
No, there was only 1,174 cases surveyed.
So how many total cases a year?
Oh, you're talking about the amount of straws being used?
Yes.
Oh, okay.
No, no,
So
straw injuries
straw
per year.
injuries. So yeah, there was only 1,174 straw injuries.
Okay.
From
So nearly 1 in 400,000. Okay. Just so I don't get paranoid when my kids are drinking a straw. Just calculating the risk.
Okay, well, when you go to the bar tonight, throw that straw away, okay? All right. Any other questions or comments? If not, we'll move on. Thank you very much. Good.
Okay, next, the title of the next presentation is Penetrating Lower Extremity Vascular Injuries in Adolescents. Be presented by Dr. Philip Kim. He's coming from Georgia, Emory University School of Medicine.
Hi, everyone. My name is Philip Kim. I'm a trauma critical care fellow at Emory University and Grady Memorial Hospital. It's a privilege to present today. We have no financial disclosures. So as many of you have already heard, firearm-related injuries have surpassed motor vehicle crashes recently to become the leading cause of death among children and adolescents in the US. Trauma centers like ours have recently witnessed a similar surge in penetrating injuries to adolescents as trauma volumes rise. That proportion has remained about the same, but as the nation's volume rise, we see more and more of this. Our study aimed to examine middle adolescent lower extremity vascular injuries in our ACS verified adult level 1 trauma center. So it was a retrospective review from 2010 to 2022 with 31 middle adolescent patients identified with ages 14 to 17, all with penetrating lower extremity vascular injuries below the inguinal ligament. We looked at demographics, injury characteristics, management strategies, and clinical outcomes, including early complications. So on average, the age was 16, with a male being 94% of the 31 patients. 100% of our population of this 31 patients had a GSW gunshot-related injury, and GCS average was 13, and our ISS was 14. 26% of our patients arrived with a pre-hospital tourniquet in place, and 32% had a normal ABI prompting a CTA study. And 55% of our patients had a hard signs of vascular injury, most commonly an absent pedal pulse. In terms of the vessels injured, there were 50 total vessels that were injured in 31 patients, with the popliteal artery and vein being the most common, with close followed by superficial femoral artery and vein, and less commonly the common femoral artery vein and the tibial vessels. And It was clearly identified nerve injury in 6% of our patients, and 39% of our patients had an associated orthopedic fracture as well. EBL on average was 1,000 cc's. In terms of surgical technique, there was a variety of techniques with reverse greater saphenous graft, often from the contralateral limb, as the most common method for arterial injuries, with ligation being most common for vein injuries. However, primary repair was attempted when able, and even PTFD grafting was done for artery and vein. Vein, I think, was done in the early era of the study. And there were 2 tibial vessels that had no intervention because they had occlusion on CTA with reconstitution, so those were not intervened. 48% of our patients received a fasciotomy. 12 out of 15 received it in the index operation, and 3 developed compartment syndrome that required a delayed fasciotomy. And 13% had an intravascular shunt that was temporarily placed first before any sort of definitive repair. In terms of our delayed compartment syndrome, as I mentioned, 10% received a fasciotomy after the index operation. There was 1 patient that developed a delayed occlusion of their greater saphenous grain graft that then developed toe necrosis, a TMA, then a BKA. So 3% of our population, and 2 patients that did develop a DVT as well. There's 1 patient that had a mortality that came in a pulseless that received a suscithoracotomy from the femoral artery and vein injuries that just survived past the operating room, but did not make it past a few hours past that. So, and then follow-up within 30 days was 80%. We had good short-term follow-up because we have all our patients follow up with the arterial duplex to look at our graft, but unfortunately we were lacking long-term data. And 2 out of our 31 patients also had came into the trauma bay again with a different gunshot injury. So there was a high rate of recidivism as well. So in conclusion, lower extremity vascular injuries in adolescents are rare with comparable morbidity to the adult trauma population. As our data shows, multiple vessels may be injured and concomitant fracture may be present. So our practice is to have a close collaboration with vascular surgery and orthopedics for all these injuries. And further work is needed to determine long-term patency rates, especially in children and adolescent patients with penetrating lower extremity vascular injury. I'd be happy to take questions.
Thank you. So thanks for the nice presentation. So this study focuses on adolescents with firearm lower extremity injury. Nearly 2/3 of your patients had a concomitant arterial and venous injuries. I don't want to make this look like we're in an M&M discussion right now, but 32% of your patients, so you're talking about 1/3 underwent the CTA. Even though you have a lot of these patients with serious arterial and venous injuries. And didn't this likely resulted in delay in management of this patient? And is this the standard at Emory, proceed with CTA when you have severe vascular injuries?
So I think for our standard is for any penetrating injuries with hard signs, so no pedal pulse or active bleeding, our practices go straight to the operating room. But otherwise, if there is a Dopplerable signal, we get an ABI, and anything less than 0.9 routinely gets a CTA. However, obviously it's at the discretion of the surgeon.
Okay, so these patients that underwent the CTI, all of them did not have any hard signs of vascular injury.
That's correct, yeah.
Okay, I mean, that makes sense. I'm just because I got a little bit curious.
Yeah, it's a large proportion. Yeah, a lot of CTAs. So,
okay. Dr. Dent?
Yeah, Dan Dent, San Antonio. I don't know exact numbers in our practice, but our threshold to do fasciotomies is pretty low. You did them, only about half the kids ended up with fasciotomies. I understand the ones that had a tibial vessel tied off didn't need a fasciotomy.
Correct.
But my question is, do you have any sense of if the development of compartment syndrome or therefore the threshold to do fasciotomy should be any different in children than it is in adults?
Yeah, I think it's hard to tell that from our data, but I think you can tell our surgeons were more aggressive or had higher threshold to avoid an index fasciotomy, and 3 out of the, unfortunately, 15 were done later because they developed compartment syndrome. All 3 of those that had delayed compartment syndrome had a concurrent vein and artery injury. So I think that's a textbook teaching is if you have artery and vein injury, you should definitely consider doing it unless you have a strong reason not to.
So that gets to, I guess, maybe what I led you to, which is, does that mean that Some people change their practice because it's a child and they don't want to put a big incision on a child's leg, and maybe that's the wrong thing to do.
Yeah, I can't speak to that, but I think more and more, I think people are, I guess it's there are different practices among different surgeons. And my practice is, if you're thinking about it, you should probably do it. That's how I was trained, because losing a leg is much more dire than getting a fasciotomy. But I definitely think that it is dependent on surgeons sometimes and how they were trained. So.
Thank you.
Any other questions? Did Dr. Kevin Daw show up? Okay. All right. Thank you.
Thank you.
Okay. Next will be Dr. Kevin Daw from Stony Brook Medicine. He will present venous thromboembolic disease and blunt trauma, what matters. This will be the last presentation.
Good evening, everyone. Sorry for the delay. I have no disclosures. Venous thromboembolic disease, their incidence and mortality remains persistent despite increased surveillance and implementation of multiple multimodal prophylactic strategies in our center and other centers. To take a closer look at this, we looked at our trauma registry data over a 10-year period at our level 1 trauma center, trying to look for any factors that we can identify to improve our risk stratification and patient targeting to improve resource allocation and outcomes. So this was a retrospective single center review. We were looking at our data from January 2009 to 2019. We included all adult patients who were blunt trauma patients. We excluded any patients who died in the emergency room or were less than 18 years old or had a penetrating mechanism of injury. Our primary endpoint was any diagnosed DVT or pulmonary embolism, and any secondary outcome was in hospital mortality. We included multiple risk factors, including the injury severity scores, whether they need an operation, and multiple other risk factors. And we ran them through several machine learning classification algorithms to assess their contribution to the risk. These are just our raw numbers. So we had almost about 15,000 patients total. About 14,000 did not have any VTEs. Only about 340 did have VTEs, making for about a 2% rate overall. It did decline over time. I highlighted a couple of important factors that we looked at. So higher injury severity score logically had an associated increased risk of venous thromboembolic events, as well as mechanical ventilation, any operation, increased length of stay, and you can see the associated increase in mortality. That being said, with the higher increased injury severity score, the risk to the individual patient is higher. But if you look at our total number of VTEs, the highest proportion is composed of patients who have very low injury severity score, less than 10. While the risk overall for the patient might be lower, this is still a significant problem to deal with. We were interested in the types of chemoprophylaxis that were used. Unfortunately, we only had chemoprophylaxis data since 2012. So only about a little over half of our VTE patients, we had data for this. We looked at this primarily sub-Q heparin and Lovenox were the main two agents that were used. At least in our evaluation of the data, sub-Q heparin did not appear to be inferior to Lovenox in terms of preventing VTE. Of the machine learning algorithms that we used, we included logistic regression, and we'll highlight some of the key predictors for venous thromboembolism with the highest odds ratios towards the bottom of the chart there. So any patients who had an operative procedure, had an ICU stay, or were mechanically ventilated. Unfortunately, our chemoprophylaxis data, we need to abstract a little bit more. We did not, because of the timing of the data that was obtained, we're not able to draw a strong relationship. We also used a random forest algorithm and highlighted the contributions to our predictive model. The key factors are presence of chemoprophylaxis, if there was any chemoprophylaxis data recorded, number of comorbidities, patient's age, and hospital length of stay. So in conclusion, our venous thromboembolic rates in our blunt trauma patients at our center has declined over the past decade. They peaked around 4.4% back in 2011 and has declined to about 1.09% in 2019. Although VTA patients in general had a higher injury severity score, VTs do occur throughout the range of injury severity scores, and the highest proportion of them remain in the lowest injury severity score group, probably because of the population or number of population. Surprisingly for our data, heparin chemoprophylaxis had a lower odds ratio for venous thromboembolic events than Lovenox did. But we would like to look closer at that data as we had a large crossover in terms of patients who started on heparin and then were converted to Lovenox. The only body region injury that was significantly associated with venous thromboembolisms was extremity injury. Head injury, which we had thought might be one key predictor, was not in our data set. Another point is that about 10% of our 185 venous thromboembolic events in the ones that we have chemoprophylactic data for occurred by hospital day one. So they may not have been preventable, probably weren't in these cases, and has implications for our practice as well. And also implications for our predictive models in terms of how chemoprophylaxis plays in. And then again, because a significant proportion of the venous thromboembolic events were still in the lowest injury severity score group, broad application of prophylactic strategies remains important in the trauma population, and targeting high-risk patients alone will not sufficiently address this issue. Thank you.
Thank you for the nice presentation. I had only your abstract prior to this presentation. I noted in your conclusions that you mentioned chemical prophylaxis was an inferior predictor of DVT. Can you just clarify that for me?
I think that because our time, we would like to abstract that data a little bit more in terms of when chemoprophylaxis was initiated. This is just our trauma registry data was just whether there was a presence of chemoprophylaxis, but it didn't say when it was started. It could be day one, could be day 3 or longer. And so our relation, we didn't show a strong relationship between chemoprophylaxis and risk of VTE, but we think that is probably why. And we'd like to go back in the charts and kind of clarify that.
I think it's very interesting that your lower ISS scores had more DVTs and so forth. Do you think it's because they were not as severely injured, so they didn't get prophylaxis, or?
I don't think that's the case. I think that, and again, I think that the key was that the proportion of our VTE events were lower injury severity scores. So it's just, I think it's just a larger population, but I think that doesn't change the fact that they have to, we need to, it still contributes significantly to VTE events.
Okay.
Thank you for the presentation. Regarding the trends of DVT incidence and the increasing ISS, have you attempted to look at the data in like survivor only patients, like patients who only survive? Because maybe there's like some kind of survivor bias in your data. Maybe patients who had higher ISS simply did not survive to that event of VTE. They just died earlier. So have you tried to look at patients who did not die?
So again, I think that we, that may play a role, but I think that, again, it might be a little, unclear, but the higher ISS was associated with a higher risk for individual patients in terms of getting VTE events. My point with the lower ISS was just that a higher proportion of VTE events is accounted for by patients who have low ISS. So these patients remain at risk for VTE events.
Thank you.
All right.
Okay, thank you. I think we're finished here. So
Yeah, thank you.
we thank and congratulate all the presenters, and I believe the reception starts in about 10 minutes, so everybody, see you there.